Welcome. Thank you for joining us today. My name is Amy Sam. I am the Health Education Project Specialist at the Maxwell and Eleanor Blum Patient Family Learning Center at Mass General.
My name is Maria. I am a public health intern at the Blum Center.
Before I get started, just want to go over a few items with you all. Please note that today's session is being recorded for educational purposes. If you're interested in viewing the recording, it'll be made available from the Blum Center website at massgeneral.org/Blum-Center. Please note that you are in listen-only mode. Everyone has muted so we can hear our guest speaker today. If you have any questions for our guest speaker, you may use the chat feature, which is located at the bottom of your screen. We'll have time for them in the end. Only Blum Center staff and our guest speaker will see your questions. Please do not share any personal medical information or questions in the chat. If you have a personal medical question, please ask your doctor. Lastly, at the end of today's session, you'll be directed to a brief survey, which we'd like to ask you to help us complete. Your feedback is important to us as we plan future programs. Okay, so next I'm going to hand it over to Maria, who will introduce you all today's guest speaker.
Thank you, Amy. Joining us today, we have Dr. Linda Hemphill. Dr. Hemphill is the director of the LDL apheresis unit at Mass General. She received her MD from Boston University School of Medicine and completed her cardiology fellowship at St. Elizabeth's Hospital in Boston. Dr. Hemphill has been involved in clinical trials of medications to lower cholesterol for over 40 years. She joins us today to give a talk on high cholesterol. Please join us in welcoming Dr. Hemphill.
Thank you. And Amy, you're going to pull up my slides, right? Yeah. Okay. And one thing I realize is that, we can go back to the title slide. The topic was high cholesterol, but in fact, as we'll see later in my talk, that may be a bit of a misnomer. But to continue, I'm really pleased to have this opportunity to talk on what really has been my life's passion, the prevention of atherosclerotic cardiovascular disease. So the title of my talk is Cholesterol, Why is it important? I got to change the title. Well, actually, what is high? I have in quotes, and you'll see, how that works out later on in the talk, and then how to manage it. Next slide. So I have no conflicts of interest. And the next slide. So prevention, the presentation overview will be, first of all, what is the role of cholesterol in heart attack, stroke, and peripheral arterial disease? And then what is, quotes, high cholesterol? And how do we manage cholesterol and the risk of heart attack, stroke, and peripheral arterial disease? And then finally, questions. So first, what is the role of cholesterol in heart attack, stroke, and peripheral arterial disease? I like to say that cholesterol is the building block of plaque in the arteries, and risk factors are the builders. Moving on to the next slide. This graphic shows you the development of plaque in the artery wall. On the left-hand side, you see the cholesterol particles circulating in the bloodstream and making their way into the artery wall through the endothelial layer. And this is happening all the time, but in all of us, but there are several factors that promote it. higher cholesterol, obviously, but also risk factors. High blood pressure, smoking, diabetes, these all make the vessel wall more vulnerable to the entry of the cholesterol particles. Once in the vessel wall, the particles become oxidized. That's the word modification there, and the particles have sort of inflammatory redness about them. They become oxidized, very pro-inflammatory, and they cause white blood cells, pictured in the middle there, to enter the artery wall from the bloodstream. Now, the white blood cells are coming in to try to clean things up, but they actually become engorged. And you see that at sort of the bottom middle there, they become engorged with the cholesterol particles and actually die and rupture and make the whole situation worse, contributing to the inflammation. So next slide. This is actually an electron micrograph of white blood cells entering the artery wall in the process of atherosclerotic plaque formation. Next slide. So this, again, is a process that, actually starts fairly early in life. It gradually grows over decades. Over on the right-hand side there, you can see a plaque rupture. You can think of it as a pimple popping. And this is the initiating event of a heart attack because a clot forms in that location when the plaque ruptures. Next slide. So atherosclerotic plaque can cause symptoms in three major vascular beds. By restricting blood flow or by totally blocking blood flow. In the heart, restricted blood flow causes angina, while totally blocked vessels, that's the cause of a heart attack. In the legs, restricted blood flow can cause a symptom called claudication, which is essentially angina in the leg. A person has discomfort in leg muscle with walking that's relieved by rest. And then finally, the buildup of plaque in the carotid arteries can lead to strokes. Next slide. So the next question is, what is, quotes, high cholesterol? So let's go to the next slide. And I like to say that high cholesterol is the amount it takes to get you in trouble. And, I have just recently a patient whose primary care referred him to me, and the patient didn't want to take statins, didn't understand. He said, all my life I've been told my cholesterol is normal. And looking through his record for according to US levels of cholesterol, he's been very normal his whole life. Total cholesterol under 200, maybe sometimes a little bit over 200. LDL's always under 130. But we'll get into why he really needed to take a statin. So we had that discussion. So it's the amount of cholesterol it takes to get you in trouble. And next slide. On this graph, the horizontal dotted line denotes the onset of clinical atherosclerotic disease. So that's angina, heart attack, claudication, stroke. Age is along the bottom. So to the left in purple are individuals with genetically extreme elevations of cholesterol from birth, known as familial hypercholesterolemia. untreated, they can actually have onset of coronary disease in their 30s. So with lower levels, onset is delayed. However, there are people with lifelong genetically very low LDL cholesterol, and that's in green over there on the right. So these people, they're rare, but they have genetically LDL cholesterols of 50 from birth, and they never get atherosclerotic disease, even with risk factors, because they don't have enough building block. Next slide. So again, the vast majority of us, and that is U.S., have LDL cholesterols well over 50. So what is the impact of the risk factors? So next slide. A potent risk factor, like smoking, can shift a person with moderate or modest high cholesterol to the left with the onset of coronary disease earlier in life than would have occurred on the basis of their cholesterol level alone. So next slide. So this is a very old slide, old data, but it makes an important point. Diabetes is a particularly potent risk factor. On the left in yellow are people without diabetes, and it shows the risk of heart attack in people who've never had a heart attack and they don't have diabetes, and it's 3.5%, 7-year risk. If somebody who's already had a heart attack, the risk goes up. But look over there on the right-hand side. These are the diabetic patients who've never had a heart attack, and they're at the same risk or slightly higher risk than the non-diabetics who've had a heart attack. So then you combine the two, diabetes and a previous heart attack, and the risk really skyrockets. Now, the good news is this is old data. It was just fairly shortly into the statin era. So the situation for diabetics has been markedly improved by the statin medications. But just to show what a potent risk factor diabetes can be. Next slide. So then how do we manage cholesterol and the risk of heart attack, stroke, and peripheral arterial disease? Next slide. There are 3 levels of prevention, atherosclerotic cardiovascular disease prevention. What's called primordial prevention in childhood and youth is to prevent the development of risk factors. At that point in life, they don't have plaque, but you want to work on diet and exercise, prevent weight loss, prevent smoking and so forth. So this is called primordial prevention. Then primary prevention is in older folks who, in all likelihood, have some plaque somewhere in their arterial tree, but it is subclinical. They've never had angina, they've never had a heart attack, claudication, never had a transient ischemic attack. But honestly, another thing I say is atherosclerosis is like wrinkles. The longer you live, you're going to have some somewhere. But the point is to prevent onset of clinical coronary disease. And then secondary prevention is people who have already had an event, or already have symptoms, stent, etc. And in these people, you want to work very hard to prevent any recurrent events. The rest of my talk, I will devote to the primary prevention. So next slide. Cholesterol is the building block. Risk factors are the builders. Next slide. So lifestyle is critical for all the risk factors. But for cholesterol, you want to follow a healthy diet, heart-healthy diet, restrict high-fat meats, eat fish. Your milk products should be 1% or non-fat. You're avoiding the saturated fats in animal products here. You want to avoid deep fat fried foods. The FDA took trans fats out of our diet in terms of something that's added but what's little known is that the deep fat fried foods, the fats they start with are healthy fats, but the very high heat generates trans fat. So you're actually getting trans fat when you have the deep fat fried foods. Read food labels. Be very wary of, the first line will say total fat, which, there are good fats, but underneath that it'll say saturated fat. And that's what you want to keep under 2.5 grams in the portion you're going to eat. And then, of course, eating fruit and vegetables and consuming whole grains. Next slide. So, and I'm going to minimize myself here so I can read my own slide. Let's see. There. The good news about smoking is that the prevalence is declining dramatically over the past, or has declined dramatically over the past 50 years. And quitting provides benefit at just 1 year. After 10 years, it is as if you'd never smoked. So that is a very potent risk factor to be dealt with. Next slide. We talked about diabetes. Avoid it. Maintain ideal body weight. Not on this slide, actually. Cardio exercise, 30 minutes, 5 times a week, actually lowers blood sugar. You drive glucose into your muscle cells when you're exercising. And so, in fact, diabetics who are on insulin, when they start exercising, can cut down their insulin dose. So exercise is also a critical part of avoiding diabetes. And then for every 1 pound you lose, the risk of diabetes is cut by 5%, and 10 pounds, 50%. Next slide. So next slide, only way to know, just add the, thank you. The only way to know if you have high blood pressure is to have it checked. Either the doctor's office or get yourself one of the arm cuffs at the pharmacy and check yourself. So normal blood pressure is under 120/80, and hypertension is greater than 140/90. And watch salt intake. It should be 2 grams or less in your daily diet. And maintaining ideal body weight also helps. Exercise helps. And of course, take medication as directed by your physician. So what about statins? Who should take statin medications in primary prevention? There are 2 groups that, right off the bat should take statin medications. Familial hypercholesterolemia is a genetic extreme elevation of cholesterol from birth that I already mentioned. And depending upon how high, sometimes statins are started as young as the age of 8. And that's if the condition is heterozygous, and for homozygous children, even younger than that. And the other condition where statins are prescribed are type 2 diabetes, is type 2 diabetes. Next slide. So how about everybody else? Primary prevention. There is a risk calculator. The primary care physician, starting at age 40, do this evaluation of risk at annual physical exams. And that evaluation of risk, developing, coronary disease, stroke over the next 10 years, is estimated using what's called the pooled cohort equation. This was developed from epidemiologic studies, the most famous of which is in our backyard, the Framingham Heart Study. And just, populations who had risk factors, populations free of atherosclerotic disease had risk factors measured, and then they were followed over time. And the impact of those risk factors was seen on risk. And so this little calculator gives an idea of, the risk over the next 10 years. And the factors in that equation are age, sex, race, white, African American, or other. Unfortunately, the current calculator does not have South Asians or East Asians or Hispanics. So, but I think the next time the guidelines come out, they will have data, enough data for those groups. The calculator overestimates in East Asians, Chinese, for instance, and underestimates in South Asians, India, Bangladesh, etc. So age, sex, race, blood pressure, total cholesterol, HDL cholesterol, and smoking status. Those are the factors in the pooled cohort equation. Next slide. So if, according to this risk calculator, the 10-year risk is under 5%, that's considered low risk, and statin is not indicated. 5 to 7.5 10-year risk is borderline, and statin may be indicated, especially if there is a family history of premature coronary disease that actually doubles one from, let's say they had 5 according to the calculator, but they have the family history, that makes it 10, basically doubles the risk. So then what's called intermediate risk is people who have a score of 7.5 to 20. And in this group, statins are considered beneficial, and the benefit outweighs any possible downside. And so statins are recommended. If the risk is over 20%, that is equivalent to somebody who's already had a heart attack or a stroke. It's basically a secondary prevention level, and that person should definitely take a statin. Next slide. So, yeah, and I already mentioned that if a parent or sibling had early heart disease, and that's before 55 in men or before 65 in women, the PCE risk doubles. The cause of early heart disease may or may not be clear. And then there's something that I've been seeing. I call it the disappearing family history. And this is, I have a 40-something patient sitting in front of me, and parents are doing great. They've been there now, but you go back to the grandparental level, and there's premature coronary disease. But the parent has been taking statin for many years. And so you may be dealing with the disappearing family history, syndrome. And again, as I mentioned, if somebody has a borderline PCE risk and they have the family history, their risk becomes intermediate, and they should probably take a statin. So next slide. I ran into a fascinating story preparing for this talk. Akira Endo of Japan was inspired as a teenager by Sir Alexander Fleming, who you all may know discovered penicillin in a mold during World War II. So Dr. Endo pursued a career in microbiology, studying mold and fungi, and discovered the first statin in red yeast rice. So Fleming initiated the modern antibiotic era, which eliminated infection as the leading cause of death worldwide. And Endo's discovery of statin has gone a long way to ameliorate our current leading cause of mortality worldwide, and that's atherosclerotic cardiovascular disease. So that's actually, just in summary, next slide. We've talked about cholesterol being the building block, risk factors, the builders, importance of lifestyle, and importance of taking statin when indicated. Next slide. These are some helpful websites you can go to for further information. And next slide. We have plenty of time here for questions. I see there are a bunch in the chat there. Does somebody want to?
Thank you, Dr. Hemphill. This was very helpful. We're now at the end of the presentation. If you have any more questions, please feel free to enter them in the chat. We do have a few questions here. Our first question is regarding diet. Are fruits and vegetables equal when it comes to lowering cholesterol, or is one better than the other?
Interesting question. It's not so much that they lower cholesterol, it's that they replace other bad things. And they're also just generally, obviously, source of nutritional value, vitamins. For instance, things like oatmeal does have some cholesterol lowering effect, but it's very, very mild. In fact, if you do a test on yourself and start having oatmeal for breakfast, you probably won't see the difference. But we know there's a difference. There is some cholesterol lowering effect, probably by virtue of binding bile acids. But studies have been done, randomized studies, oatmeal versus, but you can see the difference when you compare very large groups, but not within an individual. Oatmeal is especially helpful when it replaces bacon and eggs. So.
Thank you. We do have a couple of questions regarding medications. First is, any thoughts on the new drugs coming out for lipoprotein A?
So there is a lot of buzz on the internet on LPA. Lipoprotein little a is a particularly potent atherogenic particle. Essentially, it's an LDL particle with an extra protein on it. And we've known about it since Dr. Berg discovered it in the 1950s, I think, or 60s. And we've known that it's been a cause of atherosclerotic disease. What we haven't been able to do is treat it very effectively. Niacin, very, very large doses of the B vitamin niacin lowers LPA about 25%. But what we have now is a whole lineup of medications in development to lower LPA. The front runner is currently only being developed for people who already have clinical coronary disease. In fact, the inclusion criteria is you have to have had a heart attack. And this is very typical in drug development, where you want to go for the highest risk population to be able to most clearly demonstrate the benefit, and then you move on to using or applying the medications to other populations. I should say that LPA, I'm getting a number of people now, primary prevention, low risk, who've had an LPA measured, and they're very concerned about it. So you need to understand that LPA is it needs to be interpreted in the context of overall risk. Unless there is an extreme elevation, so we're talking about 380, 400 nanomoles per liter, it's not a standalone. It's interpreted in the setting of other risk factors. And in the current management, since we don't have medications on the market yet to lower it, is to get the LDL as low as possible. So that's how we manage LPA, very high LPA, especially in those secondary prevention populations, is with statin medication. I guess that's it. So less than 75 is a laboratory normal, but laboratory normals, you need to understand, is just they just say, okay, the top 20% are high risk of any lab report, any lab test. What you really want to know is the impact in epidemiologic studies. And you begin to see the impact on risk at about 100 nanomoles per liter. And then, as I mentioned, the really extreme level is like 380, 400. I don't know, did I answer the question?
Yes, thank you. Our next question is, are there any particular statins that raise blood glucose levels?
So they all do, a little bit. In the clinical trials, what was seen was that people who are sort of borderline diabetics and were randomized to the statin group moved over into diabetes earlier than similar placebo patients. That is totally outweighed by the fact that diabetics have so much benefit from statin. These folks were probably headed that way anyway. And yeah, the risk of diabetes is dramatically lowered by statin medications. So yes, if you're pre-diabetic and you go on a statin, you could possibly convert to diabetes earlier than otherwise.
Thank you. Can you comment on apolipoprotein B?
So ApoB is the protein on the LDL particle. There's only one of them on every LDL particle. So if you have an ApoB level, you have an idea of how many LDL particles there are. Now, in most cases, using LDL alone is adequate to evaluate risk and to treat. But there are certain situations where there's kind of a discordance between LDL cholesterol and the number of particles. And that happens primarily when triglycerides are elevated above 150, fasting triglycerides above 150. This causes a cascade of events. The LDL in that situation becomes, when it's acted upon by lipoprotein lipase, becomes a small, dense, and many more of these particles. For the same total cholesterol level or same total LDL level, there are many, many more particles. And so in that situation, it is helpful to also, look at and be more aggressive. Look at the ApoB and be more aggressive if it's elevated. Yeah. Currently, unfortunately, because none of the clinical trials were done with ApoB, for that matter, non-HDL, which is kind of is close to ApoB in its usefulness. Non-HDL is where you take the total cholesterol and you subtract the good, and everything is bad. Everything else is bad. I mean, that includes your LDL and all your triglyceride-rich lipoproteins. So we can look at non-HDL as a approximation of ApoB. Yeah.
Thank you. Our next question regarding servings of fruit and vegetables per day. Would it be best to have 1.5 servings of vegetables and 1.5 servings of fruit for each meal, considering a diet which consists of 3 meals per day?
That sounds good.
Perfect. Thank you. It looks like we have no further questions. Before we end today's session, do you have any final thoughts you'd like to share with the audience?
I think, again, my lifelong passion has been prevention, and especially primary prevention. And the lower the LDL and the longer it's low, the more protected you are. That's another thing I like to say to my patients who are going on statin, and they say, do I have to take this the rest of my life? And the lower the LDL and the longer it's low, the more protected you are. So keep taking your medication if your doctor prescribes it.
Thank you so much. Next, I will turn it over to Amy, who will conclude this session.
Thank you, Maria. And special thanks to Dr. Hemphill for today. This was very helpful. For everyone who joined today's session, as I had mentioned, this webinar is being recorded. If you're interested in viewing the recording, it'll be made available on the Blum Center website at massgeneral.org/Blum-Center. Thank you, everyone. Take care.